Okay, so today I'm going to talk about autoimmune under the microscope, but I will start with talking about what pathology is and who the pathologists are, so you know the name in the paper and the pathology report on the liver biopsy, who these are, and then I'm going to talk about what happens to the liver sample when they take it, the radiologists take it, and then send it to the lab, so you can know why. You know, sometimes it takes 2 days, 3 days, sometimes for the pathology report to come out. So it will take you in a journey to what happened to the liver biopsy. And then I'll talk about the role the pathology plays in the care of autoimmune hepatitis, okay? So pathology, it's come from Greek, and I'm not going to try and say these words, but it means the study of suffering, which is the study of disease. So in the general sense of the word in science, everyone involved in your care in the medical field do some pathology at some level. It's a vague, big scientific name that means what causes the disease, how that etiology lead to the disease process, what happens at the level of the cells or the tissue, and how that manifests in symptoms, signs, lab data, and stuff like that. But in real life, practical pathology is practiced in the lab, in the hospitals, and in the pathology department. That's what I do. So this is a very simple cartoon that you probably saw before. It's from a journal intended for the patients, and it talks about what I'm saying about the pathogenesis, just the simplest pathogenesis of autoimmune hepatitis, which leads to everyone on the field of medicine kind of tap in part of this to do their job. So basically what the cartoon shows is your liver cells and show your immune cells were supposed to be doing the job of killing the enemies, which is bacteria, viruses, and parasites. But then they lose sight of that, and they start recognizing the liver cells as an enemy, and they start attacking the liver itself. And that's the whole simplified principle of pathogenesis. And that's affect how I do my job at the pathology and how the laboratory does it. So if we think about the blood draws that you take for liver enzymes, for example, when the immune cells kill the liver cells, then all the stuff that was inside the liver cells, the enzymes that do the functions, then they leak out in the blood. Then you get high AST and ALT in the blood draw. These immune cells, when they start becoming crazy and they start attacking the liver cells, they secrete antibodies. And these are the autoantibodies that we detect in the blood and the serum. And also, when I look into the microscope, I see this stuff, this immune cells attacking the liver cells, and I see this evidence on the slide. Okay, so what do pathologists do? So I'm an MD, I'm a doctor, went to medical school, that's what pathologists are. Most of you pathologists are doctors. That's not implying the people who are going to look at your biopsy and do all the stuff in your biopsy are only pathologists. It's a whole process, a big laboratory, a lot of scientists that process the specimen. But the person who looked at the slide and issued the report is a physician who was trained in liver pathology. And if you watch a lot of TV shows, then you think pathologists do autopsies. I do not do autopsies at all. I'm not involved in any forensic stuff. I don't solve crimes. And then I've watched a couple of shows, and they show the pathologist as the one who's sitting in the basement, cold area doing the autopsy. And usually they are weirdos. All of that is wrong, except the part of weirdo may be partially right, but I do work in the fourth floor, so I'm not working in the basement, and I just work at the microscope. I do not do any autopsies. And any specimen that come out of you, not just the liver, if you have a skin dimple that the dermatologist took out, it will be examined by a pathologist specialized in skin pathology. If there's a fluid in the belly that took out, or any sort of a specimen, it will be examined by a pathologist, a doctor to look at it and give you their impression. And then I'm going to tell you how the role that we play at the pathologist in autoimmune hepatitis, okay? Okay, the people who just came, you missed all the jokes. Now it's all science stuff. Sorry. I'm done from the jokes part. Okay, sorry about that. So now we're going to talk about what happens to the liver when the radiologists take it and send it to the lab. So I'll take you in a journey so you can see what happens and why does the pathology report take a few days to come out, okay? So this is my pointer. I hope you can see my arrow, which is the best pointer I have now. If you can't see it, then in the left is the container, which is, am I going to mess up your speaker if I move?
You can carry that.
Okay. So this is what the radiologist will put the liver biopsy is. This is a small plastic cup that has formalin. So basically, in the body, the tissue gets oxygen and blood. That's how it maintains being alive. The moment they take it out of your body, the cells start to die, and everything goes into degeneration and autolysis. So to prevent that, the moment the radiologists take the biopsy, they put it in formalin. So that what we call fixation of the tissues. It kind of suspends the process. Everything stops at the moment they took the tissue out, so we can see what happens under the microscope. So that's the formalin. Let's get to our lab. This is what we call the gross room. I did not take a whole picture of the gross room, but this is where we process it. So someone there, a technologist, will take the biopsies out, put them in this paper. So these are the liver biopsies. These are the core biopsies. They're very tiny, about 1 cm long, and very thin. They count them, describe them, and then transfer them into that orange plastic thing. It's called cassette. And then we take that for processing. Okay. So the basic principle is to be able to cut the tissue. So to look at the microscope at the level of the cell, you need to be really going into high magnification. It's not working. Sorry. Not turn it on. So to cut a very thin section in the liver, it needs to be stiff because it's soft tissue. So someone smart, not me, invented a process where this machine is, the liver biopsies cassettes go into this. It takes about half a day. What happens, the machines take the water out of the tissue, take the fat out of the tissue, and put some wax in. It's called paraffin. So it becomes waxed or very stiff biopsy. So then we can cut it. And then it comes in here, this device. It's just like, you go to the deli store and they cut the meat, very slices. This cut is very thin, not like that one, but that's the simplest analogy. It is called microtome. It has a blade in here. And it cuts this very thin into 4 microns, very thin sections. A histotechnologist does that for us. And then they cut it thin, and it goes into what we call a water path. And, and then they pick it up with a slide, a glass slide, very thin glass slide, and they pick it out. And then it's just a transparent, waxy piece of tissue that, not helpful to look under the microscope. So then someone else is smart, decide to put some dyes in and dye and color it up. So then the slides go into this machine that can put some dyes in, a pink one and a purple one. We call hematoxin and mucins, and that gives the colors. And then the slides get to my desk, and that's of course where the magic happens. So this is the microscope that I have in my office. I try to get very close to the microscope so I don't show my messy office. So this is where I apologize for the allergy. So this is, the lights come from down. These are objectives that magnifies the slides, and I have these my eyepieces where I look. Over there is where my trainee will sit to look at the slides with me. So this microscope will magnify what I'm looking at to up to 400 times, so I can look at the level of the cells and see what's going on. Okay, so now I'm going to talk about the role of pathology. So first of all, we confirm or suggest a diagnosis, and I'll talk about that. And after we do that, then we give some activity score, extent of fibrosis. We help identify variant syndrome and exclude other entities. I just ran through it because I'm going to talk about it. I don't want to talk about it now. Okay, so when they define autoimmune hepatitis, they have 3 things that have to happen to call in a classic scenario. One of them is characteristic histologic features. This is my job comes here, which is when I look at the pathology, look at the slides. To say, yes, I have a characteristic histologic features of autoimmune hepatitis. Yes, this is compatible with that. Or no, that does not look like autoimmune under the microscope. I'm not the only one who makes the diagnosis. I'm one element of the diagnosis. But it's helpful to have, and I'll talk about examples and scenarios, okay? Okay, so this, as normal as it gets in the liver, because I never get a normal liver biopsies. So, but basically in the liver, as an organ, you get tubes of taking blood in the liver. We call them portal vein and hepatic artery. And then some vessels that taking the blood out of the liver, we call central vein. And then you have a duct system that takes the bile out. So that system all goes into the liver. When we look at this level of 4 micron under the microscope, this is about 200 times magnified. This is what we call the portal tract, where you see an artery, a duct, and a vein. And this is the portal tract area. It's relatively empty, doesn't have anything other than the vessels and some connective tissue. And then these are the liver cells. It's all with the pink stuff, the cytoplasm, and these are the nuclei of the liver. And they look okay. It's not super healthy, but it's okay for our sake of description. I just want to show you how it looks like. And then when autoimmune hepatitis happens, what's it going to look like? Which is when I show you the cartoon, is the immune cells that are supposed to be protecting the liver, they come and attack the liver. So I'm going to show you that. So these are multiple pictures that shows the classic features of autoimmune hepatitis. So this area was the empty area we looked at that has the duct and the vein. And I even can't see the artery anymore. It's very busy. It has a lot of cells. So these are the immune cells that were recruited from the body because they presume the liver cells are enemy. So now they're coming to attack the enemy, which is the liver cells. So they accumulate in the portal tract. So that's what I see under the microscope. Ton of inflammatory cells in the portal tract. And one of the important, I think someone probably discussed with you guys or already know that T cells, part of the lymphocytes, are the ones that attack the liver cells. Most of a lot of these small dot-like things are T cells, but there are some B cells too. The B cells are, when they get activated and they express themselves, they become what we call a plasma cell. So this is one of the classic histologic features we see in the liver. Ton of inflammatory cells, some of them are lymphocytes, some of them are plasma cells. The plasma cells have this kind of belly in their cytoplasm, and this has a lot of the immunoglobulins that when they take the blood draw, they see high level of immunoglobulin. And all these autoantibodies, they come from these cells. So I can see this and I can immediately tell what the blood will show. Because the livers are damaged, so they are swollen, they have this kind of bubbly, empty cytoplasm. So I know all the enzymes are going to go up because now the liver cells are leaky, and they come out. And I see all these inflammatory, so I know the immunoglobulin will be high because of the plasma cells. So a lot of inflammation in the portal tract, a lot of damage to the hepatocytes, and in the literature in pathology will describe some classic features like what we call a rosette, which is the liver cells can become altered and make a circle with a lumen in the middle, and that's a classic feature we see. And as I told you, the T cells will be attacking the liver cells. But when we took the biopsy out, we kind of froze the process with formalin. So sometimes we catch some, you can see the yellow arrow, some lymphocytes passing through the liver cells. They got trapped in the liver cells, and we can catch them in the action. So that's all the features of autoimmune hepatitis under the biopsy. And then we say, yes, this is compatible with autoimmune hepatitis to the clinician. The second step we do after we said, yes, this is autoimmune hepatitis, is trying to give the hepatologist a sense of how bad it is, which we call the grade, which is the severity, how severe it is, and then the stage, which is how chronic it is. So every time you have a damage to the liver cells, some liver cells die, but the liver cells have the ability to regenerate and kind of produce another new liver cells that can replace the dead cells. If the process of damage happens repeatedly, a long time, which is chronic changes, then the liver cells loses this ability, and then the body starts to replace the dead liver cells with fibrous tissue, scar, and that's what we call the staging. So I give the clinician how much fibrosis is there, which is the staging, and how much activity or how bad the liver cells are damaged. That's the grade. This is a boring table. That's not what I do. I just put it in here to show you that a lot of people have published a lot of metric system, mainly for research and for also to clinical trials and to compare between biopsies, give you a score of how bad grade and how chronic is the stage. And there are different metrics and different pathologists use different scoring system, but multiple people have been published for a long time. I'm not going to talk about that. I'm just showing you how complicated it is, the process of giving a score, a number for how bad the liver is injured. I'm just going to give you the simple form of description that we tell most of our hepatologists in the report. So let me show you my fancy circle that I drew. It took me a long time. Okay, now that's the same. So this is the portal tract, and this is the inflammatory cells in the portal tract. A lot of these are plasma cells, as I told you. But then the border of the inflammation from the surrounding liver cells is very well demarcated and clear. So this is one of the areas that we kind of grade the severity of hepatitis. So imagine the immune cells are coming to damage the liver. They accumulate in the portal tract. And then as the disease becomes bad, these cells start to get out of the portal tract and damage the liver cells surrounding them. This is what we call the interface. So interface activity. So if you see in the report saying with mild interface activity, moderate interface activity, this is this. So how much of this inflammation leaked out from the portal tract and damaged the hepatocytes on the side. This one will be minimal interface activity because they're very located in the portal tract. They did not leak out and did not damage the liver cells. I'm going to show you another one. I'm going to draw another circle. Wait for it. Okay, so this is moderate activity. So instead of the lymphocytes are just limited to the portal tract like here, they started leaking out and damaging the liver cells. And then we have a system, how much it is. Is it in one side? Is it in 2/3? Is it the whole circumference of the portal tract? Started leaking everywhere. That will be minimal, mild, moderate, and severe interface activity. And then we also grade the activity in the lobule itself. So the inflammation crossed from the portal tract, the interface, and went all the way through the liver. Now we go away from the portal tract and we see damage to the liver cells in the liver lobule itself. This will be an example of moderate activity. Just going to show you an example of severe activity. So when the inflammation is so bad, it damages a lot of the liver cells in the lobule, then you start to have collapse of the structure, empty spaces. That's all filled by inflammation or some blood or necrotic tissue, like this. This is a lot of empty spaces that you don't see normal liver in. So this is the severest form, so it will be severe activity. And usually the patient is very sick at that stage. But the liver has a very good regenerative ability most of the time, and that does not mean this will get a fibrosis, but this is a severe activity at presentation. Most of the time we get the fibrosis, what we call the staging, when we have chronic injury. So this is just a picture with our beautiful colors. That's what I do and enjoy, seeing all the different colors and the different patterns. You might not enjoy it. You just pretend it looks nice. It looks pretty good. I tried to convince my wife this is blue wallpaper, but she did not buy that. So this is the what we call trichrome stain. It stains the fibrosis as blue. So that's all scar tissue or fibrous tissue in that portal tract where the inflammation happened. Now it's healing up. So this is the very low grade on the staging, the first one step, fibrosis. It's very round and nice, but it's only limited to the portal tract. Then the fibrous tissue start to extend. You can see the arrows make tunnels out into the liver surrounding the portal tract. And then the tunnels go long distance and start connecting portal tract, will be stage 2. And then this is what we call a reticulin stain, also shows the fibrosis. You can see it kind of started to become slightly nodular because the fibrosis is going all the way and making nodule. This is stage 3. And this is a cirrhotic liver, which is stage 4, which is very difficult to see on a core biopsy, but I'll show you another picture. My wife did not like the other next picture, so it's a rated not PG, but this is an explant liver. So this is, if it's an end-stage liver disease that becomes fibrotic, then the liver, instead of having a smooth, nice surface to it and cut surface to it, it becomes like this. It's all nodular. So it's all nodular of this. This is the end stage. And at this time, we cannot tell if it was autoimmune or something else, for pathology point of view. When we look at it, it all looks the same. It looks cirrhotic, nodular, that's the end stage of the liver. To me, it looks better under the microscope. Let me show you. This is a cut section, and all these small round brown nodules is the cirrhosis, but this is under the microscope. So this is your normal liver, very smooth, nice, and good architecture of the liver cells, and this is your cirrhotic liver. You can tell, even if you're not trained in pathology, this is very nodular. It's not how the normal liver should look like. This is normal liver, and this is the cirrhosis. So this is the end stage of the process if it was not treated early. So that's the grade and the stage. So these are the second information we provide for the hepatologist. First, yes, this is autoimmune hepatitis, and then how far in the process of damage it is. Grading, severity, and then staging how amount of fibrosis we have. And I'm pretty sure they know what to do with that information. Just don't ask me. I just know how to provide that information for them. Okay. Something else that we do is help identify variants. Sometimes, autoimmune hepatitis will not have an ANA positivity that help them clinically in the lab, but we still look under the microscope and we swear that this just looks exactly like an autoimmune hepatitis classic case. So we help the clinician identify some variants like an ANA negative autoimmune hepatitis. I'm not going to talk about the overlap syndromes because I know you guys are going to have talks about that, But basically, there are other immune-mediated diseases that affect other parts of the body. So autoimmune hepatitis affect the liver cells. Then they have a primary biliary cholangitis and primary sclerosing cholangitis, where the immune cells affect the bile duct. And because they're all immune-mediated, we sometimes have overlap. So you have a picture in the histology and clinically, that's not only autoimmune, but it has a mixed picture with bile duct injury. So we call overlap. Autoimmune hepatitis / primary biliary cholangitis, or autoimmune hepatitis / primary sclerosing cholangitis, okay? I'm gonna go into details, but this is one of the things that we do too. When we look at the biopsy, we suggest maybe it's not a pure autoimmune hepatitis. Maybe it has something, other element too. And I know I ran over time because I started late, but other thing that we do is exclude differential diagnosis. I will admit viral hepatitis is not something we do under the microscope. It's all about serology in the markers and testing in the blood. And drug injury is all about clinical history. So to me, autoimmune hepatitis and acute drug injury that can look like autoimmune can look exactly the same under the microscope. But the clinician, when he talks to you and elicit the history of the, what drugs the patient is taking, then they can tell that apart. What I can do, which is very common in an area like Indiana, where people eat a lot of burgers and there's a lot of fat, is fatty liver disease, and I'm pretty sure I have fatty liver too. So these patients with fatty liver disease can have high ANA in the blood, and then the question is this autoimmune hepatitis? And then they send us a liver biopsy, and we tell them, no, that's just steatohepatitis, and I just have a picture here of a classic steatohepatitis. I'll look at it, and then the clinician will tell me the patient have high ANA. I'll tell them, nope, this is not autoimmune hepatitis. This is not how it looks like, because this is the portal tract here. We can compare to the portal tract we saw in autoimmune. It just looks like nothing. It's just some vessels, and there is no inflammation whatsoever. But the liver cells are injured by the fat, and they were ballooned. You can see the liver cells are huge, and they're white and swollen compared to the normal liver cells. So classic visual steatohepatitis. So then I will tell them, nope, this is not autoimmune hepatitis. This is steatohepatitis. So that's one of the roles of pathology, is to kind of tell differential diagnosis or exclude other diagnoses. And that's all what I do. If you have any questions, I'm happy to answer them. But now you can tell everyone you saw a pathologist in real life.
So I have a question for you.
Yes.
Liver is pretty large organ, and just wondering where, depending on where you get the sample, you get different findings.
Yes, so that's always the problem with what we call representative samples. The liver, lucky for us, a lot of the liver diseases are very uniform in the liver. So whenever you take a random core biopsy, it does give you information about the rest of the liver. That's not always the case. So sometimes it happens that, for example, clinically we think the patient has a cirrhosis, for example. Then I get a liver that looks not that bad, and then probably they just did not. So when I showed you the sample where the liver looks very nodular, you can just get a sample. Imagine getting a small sample from just one of these nodules. I'm not going to be able to see all the nodules, so it looks to be normal. But for the most part, for example, in autoimmune hepatitis, the process will not be local. It will be diffused in the liver, and a sample will tell you what the other liver has.
So if I don't mind, I'm going to share my case. So I have a very typical AIH symptoms, but when I did a biopsy, there was no findings. And my hepatologist say, well, they probably got the good sample, good part of the liver, but it's one of the pieces that I'm always a little bit skeptical about, my case.
Oh yeah, and sorry, it was off. So yeah, no, it's always, whenever you're looking at so saying I'm looking at a 4 micron of 1 cm long core biopsy from a huge liver, there's always going to be, and even when we look at resections in autoimmune hepatitis, this inflammation is not uniform in every single portal tract. If you have a severe spectrum of active hepatitis, then probably most of the portal tract will have it, and then there's a very high chance that we're going to look at it under the microscope. But if you have a mild or moderate activity, then let's say 40% of your portal tracts have inflammation, but the rest don't. In theory, you can get a biopsy that does not show those portal tracts, and that will not be diagnostic of biopsy. Most of the time, though, we get a good representative sample that reflects the rest of the liver.
Thank you.
Okay. Any other questions? You're never going to see a pathologist again. That's your choice.
So we have hepatocytes, and there's lots of other cells in the liver. Can you tell me more about a histiocyte?
Sure. So a histiocyte is one of these inflammatory cells. In the blood, we have B cells and T cells, lymphocytes. We have cells that are predominantly their job is cleaning up and also secreting some materials that help coordinate the inflammatory response. We call them macrophages, monocytes, and histiocytes, depending on where they are. If they are circulating in the blood, we call them monocytes. If they are residing in a tissue permanently, that's their job, that's their site of work, we call them, depending on the organ. For example, in the liver, histiocytes, when they are residing in the liver, sometimes we call them Kupffer cells, because that's their job. They're going to stay there, they're stationed there for life. They're not going to go anywhere else. Predominantly, the job is cleaning up damage. So there was an inflammation, there was death of the hepatocytes or other cells, and the macrophages come in and clean up. But now we know they have way more roles like that. So when they clean up and stuff, they also secrete some cytokines, and they interact and cross-talk with the other inflammatory cells. But basically, when I look at it under the microscope, when I see a lot of Kupffer cells, that means to me, even if I don't see the damage now, that commonly the patient had a damage. So either he had an autoimmune flare-up and they got treated, and then the liver was scheduled, was delayed, something happened, they got the liver a few weeks later, then I don't see inflammation at that time because they already started treatment. But I sometimes see the Kupffer cell eating up what was a damage from a few weeks ago.
Thank you.
You're welcome. Last chance. Well, then, thank you, everyone, and I'm happy to answer any questions.